Our first presenter for today is a colleague, Dr. Ravi Kishore. Dr. Ravi has over 25 years' experience in the field of cardiology, and he's the interventional cardiologist, senior adult cardiologist, and electrophysiologist at Health City Cayman Islands. He will be presenting on the holy grail of cardiovascular risk mitigation. Ladies and gentlemen, let's welcome Dr. Ravi Kishore.
Good morning, and I have the distinct pleasure, or I may say displeasure, of waking all of you up. I thank the organizers for giving me this opportunity to present a very important topic in the era of preventive medicine. It'll be encompassing the cardiovascular risk and how to mitigate, where are we in terms of reaching this goal, and how far away from this goal, and what are the factors which are possibly preventing us from reaching that goal in an effective time frame. I got it right. There is an ergonomic disadvantage. It's only the side screens which are available, and if I use a pointer on this screen, you will not know, so please bear with me. This is the workaround. So cardiovascular disease fundamentally is a very broad area. I mean, you have disease of the arteries, which is coronary artery disease. All of us know that, the blockages and heart attacks. You have electrical disorders of the heart, atrial fibrillation. You have aneurysms, so on and so forth. But the focus of this talk, considering the time limitation, is only going to be on what we call as atherosclerotic cardiovascular disease, which is a spectrum of diseases which arise because of atherosclerosis. And I'll be focusing only on the coronary artery disease part of it, not on the peripheral artery disease or the renovascular aspects or the stroke. The presentation objectives is we will be discussing the burden of cardiovascular disease in a general term, the global burden, the relevant epidemiology in conceptual sense, and what are the current strategies for the prevention of atherosclerotic cardiovascular disease, how do you assess it, and how do you screen people for the same? And what is the very important concept of residual risk, which is something which the main focus of preventive research in the heart area is on? And what are the newer targets? All of us know about the cholesterol, LDL cholesterol, but is there something which we are missing? So some aspects on the newer targets, and a brief overview on the calcium score, which is coming very rapidly into the realms of preventive cardiology. And finally, a small counterpoint on screening. Is screening providing all the necessary benefits we are supposed to have? And I shall conclude the talk subsequently. Now, coming to the burden of atherosclerotic cardiovascular disease, this is the 2018 American Heart Association statistic. This is focused on US. So this will just give us some idea as to what is happening in possibly the most affluent and the most with the best developed healthcare globally, and you can draw a parallel to the remaining regions. So heart disease continues to remain the #1 cause of death in the US. And coronary artery disease, which accounts for 50% of the heart disease, accounts for 1 in 7 deaths in the US, killing over 366,000 people a year. And the estimated annual incidence of heart attacks is 720,000 new heart attacks and 335,000 recurrent attacks. So approximately every 40 seconds, an American will have a heart attack. So this is the statistic in a developed affluent nation with a very good healthcare. So this is really going to reflect on what is happening in the rest of the world. How do you focus it where? Oh, yeah. I'm sorry, this is a slide which really needs the use of a pointer, so people sitting there may not really know what is happening. Oh, I'm sorry. Okay, so this slide represents the cardiovascular disease burden across the time, location, cause, and the risk factors. This is a global statistic. Now, this is the global, so what it's showing is the change in the cardiovascular disease burden, say from 2010 to 2019, over a time span. What is happening? What you see in red here is where the disease continues to increase or become more prevalent. This is in small sections of the world where there is economic issues and population burden. You still see that there is an increasing burden. But in the rest of the globe, you are seeing a distinct reduction in the cardiovascular disease burden, which is important, which means that whatever we have been doing over the last 3-4 decades in era of prevention seem to be working. So there is a reduction in the mortality, in the number of deaths, certainly across the globe if you take on the whole. But however, the number of deaths keep increasing because the reason the number of cardiovascular deaths is higher is because longevity is more, and when you live longer, there are going to be deaths, and the commonest way you die is the cardiovascular. So in that sense, although the curve is quite shallow, the number of deaths are increasing, but overall mortality rate has definitely come down. And certainly, the burden is much more in highly populous countries like India and China. It's purely a reflection of the population dynamics and to some extent the economic burden. Whereas in the developed countries, it is certainly, the burden is coming far lower. And if you look at the kind of cardiac disease which is responsible for the mortality, more than 50% is due to coronary artery disease, that is to blockages in the arteries of the heart, which results in heart attacks. And if you do the same statistic, examine the same statistic with respect to the risk factor burden, over the last few decades, what has happened is there is, the ranking of the risk factors has not changed significantly. It continues to be cholesterol, hypertension, diabetes, so on and so forth. What has happened is the smoking, the impact of education on smoking has certainly been very effective, and the smoking has come down, whereas one of the new epidemics now is the obesity epidemic, which is possibly becoming a very important risk factor in this whole scenario. Now, if you look at this slide, this shows the changes in the age standardized mortality rate and deaths. Again, from 2000 to 2019. This is the WHO statistic. Now, what is obvious here is that, I'll just give you the summary of the slide. What you see on the left side is the age standardized mortality rate, and what you see on the right side is the deaths. Now, in most of this is basically examined as a globally low-income countries, middle-income countries, high-income countries. So it's basically based on the economic strata and the global data. Globally, there is definitely a significant reduction in the age standardized mortality rate. And although the deaths are going to go up because of the increased longevity. It's only in the high-income countries you have a distinct reduction in both the age standardized mortality rate and a reduction in the number of deaths. And this is a reflection of very effective healthcare, very effective preventive strategies, and very effective and timely intervention in cardiac disease. Now, in the Caribbean, I really did not have, I tried a lot to get the right, some kind of data, but unfortunately, I couldn't access the data. But what is available is there is a a statistic available on a 2015 publication that the Caribbean region is no exception to the global pattern, with a mean of 32% of total mortality per year from cardiovascular disease. This is all heart disease put in perspective. It is not just the coronary artery disease. The reason why we may not have accurate statistic is that the traditional risk scores which are used, which I'll be alluding to in the next few slides, are not applicable in the Caribbean because this population has not been studied in the cohorts of the population which was used for deriving the screening scores. So we may not be able to use these screening strategies in the Caribbean. For that reason, the accurate data may not be really available. In fact, if you use these particular models, some of the traditional models like the Framingham, the Assign, the QRIS models, you could actually underestimate the risk of intermediate and high risk cardiovascular disease. Now, what is the preventive strategy which we are all familiar with? The entire credit for this, the concept of preventive strategy in atherosclerotic cardiovascular disease should be given to the Framingham study, which very briefly, Framingham study is a longitudinal prospective study which is still ongoing. It was initiated by the US Public Health Service way back in 1948. And the cohorts are being added, the next generations are being added. And using that data, most of the risk scores have been derived. So the strategy is using these risk scores to assess the risk of an individual patient, individual person, or individual population dynamic. And once you identify the high-risk population, you target the risk factors in this segment. And certainly, whatever data that has come out from Framingham study and whatever it has taught us, all the issues on cholesterol, hypertension, diabetes, smoking, and the education consequently through the various societies across the globe, Cayman Heart Fund here, it's been a very good association between the societies and the public health systems to use these risk scores in giving an impact on the preventive strategies. So you target the risk factors, and that is what is going to help in mitigating the risk. Now, what are the traditional risk scores which are pretty popular? The most common is the American College of Cardiology, American Heart Association pooled cohort equation. This was derived from a cohort of population. All the risk factors were analyzed, followed up, and based on the disease pattern, they derived a scoring system, which is available online. It's an online calculator where you can feed in the data, and then that's going to give you a 10-year estimated risk of having a cardiovascular disease. So using that risk, you can target the patient's risk factors. So that is the basic principle. So, but this score is useful in US. It's not really applicable outside of US. Even in US, it's not applicable to the broader population of other ethnicities like Asians and Hispanics. So that is because the cardiovascular disease burden is ethnicity dependent. And so that is the problem is one size does not fit all here. There is a risk score from Canadian Cardiovascular Society, which is based on the Framingham risk score. It's a modified risk score. And the other one is the European Society of Cardiology has a score and a score 2 risk chart. I'm not going to go into details of the risk charts because that itself is a major talk. And I'm going to give you an overview of these, that's it. So the score chart has a particular advantage over other risk scores in the sense that it has factored in the ethnicities and the part of the economic status of the country. So there's been slight modification on the ACC-AHA risk score. And the UK uses the QRISK tool to assess the cardiac risk. Now, what are the caveats of the risk scores? As I mentioned, the focus has been only on the traditional risk factors, what we know: hypertension, diabetes, smoking, cholesterol, obesity, and other minor risk factors. So maybe that provides only a modest discrimination for the atherosclerotic cardiovascular disease events. It can underestimate risk in a patient from different racial and ethnic backgrounds. The lower socioeconomic brackets, it can underestimate the risk, and it can overestimate the risk in higher socioeconomic group who have a very good access to healthcare and to preventive strategies. And a very important disadvantage of these risk scores is they have not taken the SDOH. It's an important concept currently. It's the social determinants of health, which play an important role in the incidence of disease. This briefly encompasses access to exercise, say you don't have enough playgrounds, access to good nutrition, access to good timely health care. So these are the social determinants and mental health issues. All these are very important influencers on the overall cardiac risk. And none of the risk scores have seriously taken the social determinants of health into consideration. So all these factors may be one of the reasons why your predictive ability using a risk score may not be perfect. So is the risk-based approach working? Okay, we are going through all these risk scores. We're taking an effort to sit with the patient, work through the risk score, calculate his risk score, tell him that, look, your 10-year risk is so and so. Is that working? Now, this is the data from UK. It's an old slide, but it gives a very nice view that the death rates from the circulatory disease in England from 1993 to 2000, there's a distinct fall. There is no question that there is a, whatever we are doing is very clearly working. Yeah. So, I mean, the way it's going, we should all be guaranteed to be immortal by 2026, which hopefully will happen. So this is a very, very important study, which I will spend a couple of minutes more than what I should. So this is again from that iconic Framingham database, which we have accumulated data of over 60 years now. So this, in this study, very recent publication, it examined the temporal trends in the remaining lifetime risk of cardiovascular disease among middle-aged adults across 6 decades. So what it did, just to give a simplistic, explanation for all this written. So they divided a cohort of patients in the last 60 years into 3 time zones called epochs. The first 20 years, the middle 20 years, and the latter 20 years. And they looked at the remaining lifetime risk. Now, what is remaining lifetime risk? It's a new statistical concept where you define the risk of developing an outcome over the remainder of one's lifespan at any given age. For example, when you do the ACC-AHA risk score analysis, you give the 10-year risk. Okay, you're not giving beyond that. So at the age of 45, at the age of 50, what is the risk of developing in the rest of his life a cardiovascular event? So this is what they focused on, and they divided the time zones into 3 and compared the changes in mortality in these 3 time zones. So what did this show? So this is the graph. It's very obvious from the graph. Now, what it shows here is that this is the first epoch or the first time zone. This is the first time zone. This is the second time zone. This is the most recent 20 years. What you can notice very clearly is that there is a definite reduction in the risk of dying. People do die. I mean, you have to die. So there are people. So your age of death is possibly going, it's getting delayed, what's happening now. But you still have a remaining lifetime risk. And this is very clear both to male, female, and to the whole population. So in spite of the fact that whatever we are doing is working, which is very clear from the data, it's not working enough. So to gain that immortality, we have to do something else. So that is what is the residual risk, the concept of the residual risk. Bear with me, yeah. So the summary of this particular analysis was that the life expectancy clearly rose by 10 years in men, 11.9 years in women, across the epochs, that's the time zones, whereas the remaining lifetime risk of ASCVD also declined between the time zones. However, what is important clinical implication of this analysis is that it underscores the need for continued and more effective primary prevention efforts with better screening for risk factors and lowering them more effectively for us to achieve that holy grail of immortality. So this is where we come to the concept of residual risk. Now, residual risk has been defined as the risk of cardiovascular disease events that persist despite treatment for or achievement of targets for risk factors such as low-density lipoprotein, cholesterol, LDL cholesterol, blood pressure, hypertension, glycemia, education on obesity, nutritional health, everything. I mean, once you have exhausted all this, you still have a residual risk. And this is, so what is responsible for the residual risk? Are we missing something? So the explanation, the possible theories. So the emphasis thus far has been on traditional risk factors. You know, like I kept on harping about hypertension, cholesterol, diabetes, smoking. It is so much in the lay media, the press, that all of us know about it. Everyone, you know, this is what all the executive health checkup screens emphasize on, and this is where you, when you see a patient and you talk to him about preventive, this is what you focus on. So were we doing enough? Was the LDL target sufficient? For example, you know, if you look at the lipid profile, are you happy with the LDL cholesterol with respect to the overall risk of the patient? And was the target low enough? Were we missing something in the whole lipid paradigm, which is actually a bigger influencer? And was the risk approach really accurate? That's what is the next few slides will focus on. So so then came the concept of the risk enhancers. When we realized that the conventional risk factor based approach was not working, slowly we started adding the risk enhancers. So what are some of these risk enhancers? So one of the very important risk enhancer, in my opinion and in my experience very clearly, is the family history of premature atherosclerotic cardiovascular disease. So this definition is ambiguous, of course. It's a man-made definition. So males, if you have a first-degree relative who had a premature cardiac event, heart attack or stroke, atherosclerotic event, you know, it could be any of those. It's just not heart attack. Males less than 55 years, females less than 65 years, you know, if you're first-degree relatives, mother or father. There is a primary hypercholesterolemia with a cholesterol consistently between 160 and 189. Metabolic syndrome. Metabolic syndrome is again a clinical situation where there is a combination of obesity, hypertriglyceridemia, diabetes, and hyperuricemia. So many. It's a constellation of factors fundamentally, but dominated by diabetes, hypertriglyceridemia, and truncal obesity. Chronic kidney disease with a eGFR of 15 to 59. Chronic inflammatory disease, this is really very, very important, you know. You have a patient without everything else, all the risk factors are completely fine, but she's a rheumatoid arthritis or he is a rheumatoid arthritis. psoriasis, HIV, SLE. So this inflammatory component, which adds on to the risk, is something which we are understanding now very clearly. History of premature, I'll just discuss this a little more detail in the next slide. In the lady, history of premature menopause before 40, history of pregnancy-associated issues like preeclampsia, high-risk ethnicity, South Asian. It's a very high risk for coronary artery disease. We notice on the island, ethnic population from Philippines seem to have a more severe coronary artery disease, more severe diffuse disease, and incidence of events much younger in their age. Lipid biomarkers, I'll discuss them in the next slide, and the social determinants of health. These are important risk factors. Female-specific risk factors is something which is, again, increasingly being emphasized now. The CVD is the leading cause of death of women in US and worldwide. And the recent data definitely suggests a stagnation in the improvement of this risk status, in the risk of deaths are not coming down. In fact, there may be an uptick in CVD mortality. Actually, after COVID, there's been an uptick in the female CVD mortality. The risk scores generally seem to overestimate the risk. One of the reasons is the representation of females in most of the studies which were used to glean the data for the risk scores had underrepresentation of women. And that is being addressed too in some of the new cohorts. And some of the very important female-specific risk enhancers are autoimmune disease, early menarche before 11 years, or early menopause. This definition is varying, some have 40, some 45. Polycystic ovarian syndrome, consumption of oral contraceptives, and very importantly, hormone receptor, the HRT. Infertility, grand multiparity, and adverse pregnancy outcome. These are all female-specific risk enhancers, and you should focus better preventive strategies in these ladies. So let's go back to the cholesterol, LDL cholesterol. From time immemorial, I mean, since I started my medical school, this has been the focus, and the data is very clear. The data is very clear. The graph is very clear. The lower the cholesterol, the risk of your coronary artery disease is less. This is proven across multiple statin trials, multiple databases, the Framingham study. So there's really no doubt about it. It's not a hoax. It's very clearly, in a lot of lay press, it's taken as a hoax, the whole concept of cholesterol and statin, but it's not true. It's a real. This is one of the most clearest data that we have got in cardiology, and possibly one of the reasons why there is a reduction in cardiac mortality is the knowledge that cholesterol and heart disease are linked. So were the targets appropriate? So in the sense that, all of you would be aware, earlier, way back, when we were starting people on statins, we used to use a target of 100 milligram per deciliter. And then the next year, it came as 70. When we realized it was not working, the LDL goal came down to 70. And when that was not working, the current goal is 55. That 55, the lower the better. The lower the LDL cholesterol, the better. So one of the reasons why there is the downtrend in the cardiac mortality is that the knowledge that you need to have, the cholesterol goal has to be lower than what used to be the standard for reduction. So this again obvious from the recent studies. You could see that there is a very significant reduction in mortality as the LDL cholesterol comes down further. And there is no clear threshold at the lower end. Now, how low is low? How low should you go? You have people with LDL cholesterol of 30, 35, 32. Should we go to that level? So what the data shows, what the scientific data shows from one of the best data we have is from the Fourier trial. All of you have heard of the drug Repatha, evolocumab. So the Fourier trial looked at Repatha, and the people with we on Repatha had achieved a LDL cholesterol of even 30, 32 milligram per deciliter. And the mortality was clearly much lower in this segment of people without any side effects. So it's not just how low you go. What is also important is how long it was low. So here comes the concept of LDL burden. It is how long your arteries were exposed to high cholesterol is an important risk factor. Now let's say your LDL cholesterol, you have heterozygous familial hypercholesterolemia. Your LDL cholesterol has been about 140, 150 from childhood. So your arteries have been pummeled with cholesterol-rich blood for 40, 50 years. And that can be more toxic on the vessel wall. So that is the LDL cholesterol burden. How long and how low? So it was, you have the target. So this is very obvious from this very interesting slide, which shows 3 different types of studies. This is a Mendelian randomization studies. No details, because it's a difficult concept to explain, except that you have a median follow-up of 52 years. It's a genetic-based analysis. This is a cohort studies with a median follow-up of 12 years, randomized controlled trials, which is with a follow-up of 5 years. You can see that the Mendelian randomized, the chance of you having a coronary event is very low as the follow-up is longer. So the longer you have a lower cholesterol, the chance of you having an atherosclerotic cardiac event is lower. I hope I conveyed the message there. So the risk reduction is based on the total duration of therapy. This is what is the summary. Again, this is a complex slide, but in general, what you notice is that if you have a lower cholesterol for a longer time, the chance of you not having an event is much higher. So you start early, you start the preventive strategy to lower the cholesterol early, decrease the LDL cholesterol as low as possible. Eventually, you'll really be able to reduce the risk of developing ASCVD. The goal of immortality by 2026, right? So what's the best time to start LDL lowering treatment? Really, we are not sure, but it is very obvious that you have a LDL cholesterol very high. So the guideline is if the LDL cholesterol is more than 190, it's a class 1 indication to start statin therapy, irrespective of anything else, age or anything. So it's a decision which is complicated. It's a shared decision making, but it's important to understand if you have to prevent an event in an individual, you have to identify the risk early on and start the treatment early on. So there are a number of strategies to control the LDL cholesterol. It's not just the statins you have. I'm not going to go into details of pharmacology. It is just telling that there's been huge advances, with the latest advance being FDA approval of inclisiran, which is a drug which you can take once in 6 months, injected subcutaneously once in 6 months, and that is lowers LDL cholesterol to levels like Repatha. So this is some of the advances. So we have various options. I'm not going to go into details of the statin intolerance, which is supposed to be more of a myth than a reality, but that's a different session altogether, but I'll not go into those details. I'm not mastering this. Do I tell it to you? So, but the 50% of heart attacks occur despite normal cholesterol level, which is a question, you know, doc, I don't have any, I don't do anything, I have low cholesterol, I don't smoke, I don't drink, yet I have a heart attack. So this is a question which we keep getting asked, all the physicians, we get this retort from the patients. So what is my risk? So this is where the rest of the lipid panel comes in. Yeah, that's me. Where do I point this to? Just switch it off. Can you put the slides back on, please? There's still 25 minutes of this harangue left. Okay, now this is a patient, our own patient, with a 60-year-old male with 3 PCIs in 2 years. I'm sorry, it may not be very obvious, but the LDL cholesterol in this patient is 27. It can't be lower than that, right? 27 on 40 milligrams of rosuvastatin, and yet he's had 3 angioplasties since 2 years. His lipoprotein A is normal, apoprotein B is normal. Everything seems to be normal except the triglycerides are a little elevated, 226. Can you move the next slide, please? Oh. Yeah, I got it here. So there is this residual risk now. So this is the study, IMPROVE-IT study, which has shown that in spite of lowering the cholesterol to significant levels, you still have a residual risk. So the residual risk is due to increased triglycerides, elevated lipoprotein A, high sensitivity CRP, non-STL, and other untreated risk factors. This is what has now not been noticed, and this is what is possibly responsible for the residual risk in spite of good effective cholesterol lowering. So should we look beyond the LDL cholesterol? Are we missing something? Yeah. So a very brief lipidology lecture now, okay? So you have HDL cholesterol. We all know it's a good cholesterol. LDL cholesterol is what we are all taught as the bad cholesterol and is what is the main target for the risk. But is there something beyond the LDL cholesterol? So the concept is that there are a set of atherogenic lipoproteins which promote the formation of the atherogenic plaque. So these could be a lipoprotein little a, I'll discuss it briefly, IDL, this intermediate density lipoproteins, VLDL, and chylomicrons. So all these are what are called as a triglyceride-rich lipoproteins, and these are possibly responsible for the risk accentuation in patients with coronary artery disease. And if you look at the composition of the atherosclerotic plaque, the major component is possibly formed by the TGL-rich lipoproteins and lipoprotein A. LDL is contributing to a part of the plaque, but certainly there is a big contribution from LPA and the remnants. So beyond LDL cholesterol is what we are looking at. Now, in what way are the triglycerides really responsible for the risk? So very briefly, it's a very interesting concept. So the lipoprotein particle is transported in the transport mechanism. It carries one LDL particle for each protein. Now, if the particle is composed of triglycerides, there's less space for the LDL cholesterol. So which means more particles have to be there to transport the LDL cholesterol. And the more LDL circulating is what is going to produce the toxic impact on the vessel wall. And ApoB100 is another structural backbone of the lipid complex, which is what, when measured, it possibly may give a better reflection of the atherogenicity of the blood rather than using the LDL cholesterol alone. In fact, if you have a patient with high triglycerides and you measure the ApoB100, the population, say the patient with a high triglycerides and ApoB100 is going to be at a higher risk than the patient with a high triglyceride and a lower ApoB100. So this is indicative of a high atherogenicity. And raised triglyceride concentration are therefore an additional risk causal risk for cardiovascular disease. Inflammatory components of atherosclerosis are modified by the triglyceride-rich lipoproteins. Elevated triglycerides associated with higher CV events and overall mortality in large Italian cohorts at low moderate CV risk. This is a recent study based on which triglycerides are coming back into fore. And in a large statin-treated cohort from a Copenhagen general population study, elevated triglyceride-rich lipoproteins levels were associated with much higher mortality. So some non-traditional risk factors, drivers of arterial inflammation, is the summary of this slide, where the triglyceride-rich lipoproteins are possibly the drivers of risk for the active atheroma or the acute coronary syndrome precipitation in some of these patients with normal LDL at recurrent cardiac events. Now, what is lipoprotein A? See, lipoprotein A is a type of lipid which is actually a combination of apolipoprotein A, apolipoprotein B, covalently bound to the LDL cholesterol. So, very briefly, it's a very complex molecule, and we still are not sure whether we are measuring it correctly, whether the measurement techniques are accurate. But what is clear is that it's genetical. So one-time measurement is possibly enough, and a high lipoprotein little a is definitely an important contributor of cardiac risk. And the recommendation is that in the lifetime, every one of us should measure the lipoprotein A at least once. And this is the most irritating part of it. Yeah, I'm sorry, yeah. So the lipoprotein A has shown a very clear risk association with aortic valve stenosis, heart failure, total cardiovascular mortality, stroke, peripheral arterial disease, and all the cardiovascular events. And this is the UK Biobank study, which has very clearly shown the association of LPA with cardiovascular disease, fatal cardiovascular disease, coronary artery disease, stroke, at a level of 70 milligram per deciliter. But what is recommended is, if it is more than 50 milligram per deciliter, it is possibly a higher risk, and you have to target all the risk factors very aggressively in this patient. So the recommendation is LPA measurement should be considered at least once in each adult person's lifetime. So can we treat elevated LPA pharmacologically? Unfortunately, we don't have a drug for this. Possibly niacin, as studied in Denmark, might make reduce LPA by about 10 to 15%, but there is really no drug which has clearly been shown to impact LPA. So in summary, we have, in terms of the lipid management, what are the targets? So you have in the residual risk, you have the residual cholesterol risk, where the LDL target should be as low as possible, maybe 55, not just 100. There's a residual inflammatory risk, which is assessed by measuring the C-reactive protein. I have not gone into details on that because of the time issues. So CRP more than 2 milligrams is possibly a risk factor. And the residual thrombotic risk, it is there, but we don't have a biomarker asset, and that's one of the targets of the current studies. However, for the residual thrombotic risk, if you look at some of the disease studies on the peripheral arterial disease, the rivaroxaban low dose has been used to prevent this component of the risk, but it's not been proven as yet in large randomized controlled trials. The residual triglyceride risk, triglycerides more than 100 is taken as a risk, but I think that's too low, maybe 150, 200. You have a new drug which has been, which is now FDA approved and widely used in US, Vascepa. It's a purified form of a fish oil. You need to take 4 grams per day, but that is one of the drugs that is being touted as an important therapeutic option to reduce the residual cardiac risk. And the residual lipoprotein A risk, we don't have a proper medicine, but when you see a patient with a high LPA, you have to modify every other risk factors appropriately. So a lot of people who have high LPA get into panic, but we have to try to assure them that just what it means is that you have a higher risk and just manage all the risk factors appropriately. Well, is the battery not working in this or something like that? Okay. And a brief discussion on coronary artery calcium. All of you are aware that it's a very important screening tool now. Coronary artery calcification is fundamentally contributed by smooth muscles of macrophage apoptosis. This is the hallmark of atherosclerosis and consequently ASCVD. And a coronary calcification detected on imaging is a surrogate of a plaque, atherosclerotic plaque. As you can see on the CT scans, it's a very simple test done in few minutes. And it's an ECG-gated study, and the calcification burden is a reflection of the other plaque burden. It only means that you need to be more aggressive in risk factor management in these patients. And there is a strong correlation between the coronary artery calcium and the atherosclerotic plaque. So as the CAC increases, the plaque burden is more, which only means, it doesn't mean that you have to subject him to a stress test and angiogram and other things. It only means that you have to tackle his risk factors more strongly. So on the CAC, the current role, it's an important risk enhancer in people with borderline ASCVD risk. So you have a patient with a strong family history, he's 45 years, he's concerned, he's mildly elevated cholesterol. So you can use calcium screening to assure him that his risk is low. It can also be used as a guide to initiate or de-escalate aspirin or statin. It can be an important motivation tool in statin cynics. You know, people say, I'm not going to take statin, come what may. And his calcium score is 1,000. You can sit across the table and convince him, look, to reduce your chance of having a heart attack, it is better to take a statin. And it can also be, you can use it to de-escalate. You have a person with a 140 milligram cholesterol. You're not sure whether you should give him statin. If the calcium score is 0, you could possibly avoid giving a high-dose statin to this particular patient. But it's important to understand that CAC alone cannot be used as an indication for stress testing or invasive angiography. And a 0 coronary artery calcium is an important negative risk factor, especially in males. Not so sure about females, because I've seen ladies with a 0 coronary artery calcium having cardiac events. So this is coming to the guidelines in patients with intermediate risk of ASCVD by pool cohort equations. CAC can be used to reclassify the risk upward or downward, and it can help in deciding whether we should give him aspirin or give a higher dose of statin, lower dose of statin, or no statin at all. So this can be skipped. So now, are we on the right track? Now, this is again a very I'm sorry you're not, I don't think you are able to read it very clearly, but in summary, this is a very recent publication, just this year, Don Kava's trial, done in Denmark. And Denmark is very famous for doing highly eponymous cardiovascular trials, beautiful trials. They have wonderful medical care, wonderful medical system, very organized healthcare system. And so they analyzed 2 sets of people. They subjected one group to extensive cardiovascular screening, having ECG calcium scoring, ankle brachial index, checking for lipids, sugars, and there was one with usual care. And at the end of 5 years, what they found was something which will shock the administrators who we like to do executive health checkups and make a lot of stuff, right? Yeah. So that there was no difference between extensive screening population and people who are not screened. So the extensive cardiac screening possibly did not contribute to reduction in mortality. There were some caveats in the study. It included predominantly male. There were very few females. They gave an explanation for that. and maybe it was not longer enough term. But however, the message from this trial is very clear, that random screening may not be beneficial. So maybe you should target the screening to certain high-risk populations and use the data more intelligently rather than on a knee-jerk fashion. So conclusions, ASCVD is a complex syndrome affected by several factors which we discussed. Traditional risk scores form a foundation to establish a baseline risk for ASCVD. They give you a good information. Significant improvement in ASCVD prevalence and mortality statistics, but the residual risk exists. And the residual risk can be addressed using the risk enhancer concept. We are so near, it's so far from the Holy Grail. Yeah, that's the usual thing. Thank you very much. It's a nice Jamaican prod. So don't fall for all the stuff you hear. Huh? Thank you very much.